let's go ahead and get started. Good afternoon, everyone. We appreciate you coming here. My name is Dr. William Slattery of the House Institute Foundation. I'm pleased to welcome you to today's seminar entitled NF2-Related Schwannomatosis, Hearing Preservation and Restoration Options. Our webinar today will walk us through several areas. We'll begin with the webinar's objective, then provide an overview of NF2 diagnosis. From there, we'll then dive into our NF2 subtopics, discussions with our speakers. We've got a great group of speakers today, and then that'll be followed by a question and answer session where we hope to be able to address your questions. We're honored to be joined by three esteemed colleagues, clinicians and researchers, each of whom have shared their insight or will be sharing their insight in NF2 management. But before we begin, I'd like to extend a special thanks to our sponsor, the Children's Tumor Foundation, who we've been partnering with, and they've been grateful, they've been wonderful to work with, and they're providing support to make this event possible. So let's go ahead and get started. We will be recording this and be putting it on our website. There is quite a bit of other information on our website you're welcome to see. Also, personal information will not be shared if there's any questions that come up later, but you can put questions into the chat, and again, we'll try to address those later in the presentation. And then the objective today is to educate attendees on the current strategies and emerging technologies for hearing, communication, and restoration in individuals with NF2-related schwannomatosis. We have our experts here that are going to be talking to us. Experts include Dr. Hussein Mahoubi, who's board certified in head and neck surgery with a fellowship training in neurotology and skull-based surgery. He's focusing on diseases of the ear and hearing. He completed his residency in otolaryngology at UC Irvine, followed by postdoc research fellowship at the same institution. And then he spent 2 additional years completing a fellowship at House Ear Clinic in the UCLA, where he advanced his skills in cochlear implants, stapedectomy, and complex ear and lateral skull-based surgery. Dr. Isaac Cooley is a cochlear implant audiologist at House Ear Clinic, PIH, a Good Samaritan Hospital in downtown Los Angeles. He specializes in cochlear implants, hearing aids, and has special expertise in auditory brainstem implants. He earned his doctorate of audiology from Pacific University, and he serves as a part-time adjunct faculty member at Cal State Northridge. And then Dr. Rebecca Hale is a cochlear implant audiologist with special expertise in auditory brainstem implants. She has a robust background in the medical device industry. She currently serves as senior clinical technical manager at Cochlear Corporation. She earned a Doctor of Audiology degree from East Tennessee State University. I'm William Slattery. I've been at the House Clinic for many years. Also ran the Department of Defense's Natural History trial with NF2, and I've been involved in quite a bit of work with NF2. So I'd like to go ahead and talk a little bit about just an introduction of NF2 as we kind of talk about the definition and the clinical characteristics. This is a picture of our downtown campus at the House Ear Clinic, the House Ear Institute Foundation, and PIH Good Samaritan Hospital, which is where we're located near downtown Los Angeles. Skies aren't always blue, but many times are blue in downtown Los Angeles. So you're always welcome to come visit anytime. Next slide. So as we talk about NF2, one of the things that I think is a big thing to bring up is just that the nomenclature for NF2 has recently changed. The definition of NF2 for the most part has been the same, but in 2022 in medical genetics, there was an international consensus statement that was worked on and published, and basically trying to define the difference between what I would consider to be classic NF2 and schwannomatosis. Schwannomatosis is a disease whereby people get multiple Schwann tumors around the body, but many times they do not have the hallmark acoustic neuromas or vestibular schwannomas that is characteristic of NF2. And so the new names are basically NF2-related schwannomatosis, and then the other is schwannomatosis, and it's actually defined by the genetic type. And so one of the issues that has come up, because genetic testing has become so good, that many times people are now actually we're able to determine exactly which abnormal gene is associated with the patients with schwannomatosis. Obviously, the NF2 gene is still the chromosome 22, but that gene is also responsible for NF2. So the issue is, or basically the bottom line is, anyone with NF2 or schwannomatosis should make sure that they have genetic testing completed so that we know exactly what the phenotype is. Next slide. When we think about NF2, as I said, it's still bilateral acoustic neuromas is the hallmark of the disease. Next slide. If we look at this, one of the problems that we always have when we talk about NF2 is with these vestibular schwannomas is, can we predict if they're going to grow or not? When do we do intervention? What is the timing of it? What type of intervention is done? And of course, if we don't do treatment, then we run into problems with complete deafness. Next slide. The patients with NF2, those of you who are out there know this. Some people have very tiny little tumors, which we can see, and then some medium-sized tumors, and some can have quite large tumors. And many times we'll see very large tumors in the face of normal hearing. Next slide. What we do know is that the incidence of NF2 is about 1 in 40,000 live births. There does not seem to be any ethnic or gender preferences. About 50% of people will have a family history of NF2, and the average age of diagnosis is 22. Next slide. We do know that there is an association between the genetic abnormality and the amount of tumor burden that someone has, meaning how many tumors they have. Those that have what we call truncating mutations will many times have a much more severe outcome of the disease, meaning many more tumors. Those who have a milder or maybe just one gene shift will have a much milder phenotype. They many times we'll just see people with just 2 acoustic neuromas that present in midlife or later years. Next slide. Next slide. So we do know that when we looked at, this was the natural history study, we looked at 450 patients with NF2. We found that it was average equal between males and females. Typically, the first symptom was hearing loss in about 30% of patients, and many patients had no symptoms at all. Next slide. And that's because they were diagnosed with with family history of NF2. Next slide. And this is what basically we saw is about 1/3 of patients present with hearing loss, 1/3 of patients present asymptomatically, and 1/3 of patients will present with some other neurological symptom, many times spine disease or some other tumor that may be presenting when people are actually diagnosed. When we look at the average age of diagnosis, we know there's a big difference between the age of onset, meaning the time when people had their first symptom and when they were actually diagnosed. I believe with MRI scans, this is getting a little bit better where people are being evaluated, but I still see patients, for instance, who were diagnosed with a spine tumor and nobody worked it up and to make sure that they had other issues, for instance, in childhood. And so there's usually an average delay in diagnosis of about 5 to 7 years from the age of first symptom to when people are actually diagnosed. Next slide. Next slide. So one of the things we know about NF2 when we talk about hearing is that there is a difference in the histology of NF2-related tumors and those of sporadic tumors. So what you see here is this is a slide showing the cochlear nerves and their relationship to an acoustic neuroma or vestibular schwannoma. So the cochlear nerve fibers are many times with sporadic tumors are on the outside, but with NF2, you can see how it's kind of spread. Those dark lines are spread throughout the middle of the tumor. And unfortunately, that makes hearing preservation that much more difficult in NF2. Next slide. One of the things that we see with NF2 is we can see multiple other types of tumors. Vestibular schwannomas are the hallmark, but of course, next slide. Meningiomas can be seen in this picture. Next picture. Sorry, I don't have control. There we go. We can see there's these large white masses, the meningiomas in the brain. Some people just have multiple meningiomas or have plaques of meningiomas, meaning the whole meninges are thickened. Here we see lower cranial nerve tumors and also meningiomas that are involved with the tumor. Next slide. And so actually, let's go to the next slide. I don't have control, so I can't go quite as fast. Next slide. we do see spine tumors in certain patients. When we looked at our natural history trial and compared it with other centers, what we found that about 60% of patients had meningiomas, which is fairly consistent with other centers. Spine tumors were a little bit more, about 60%. And then also people many times would have different kinds of skin tumors that would be found. We also found that there are certain groups of people that will sometimes have problems with skin tumors as well. So the bottom line is we talk about hearing issues. With vestibular schwannomas, it's always difficult to determine when the growth or symptoms will occur. Can we do something to stop the growth of the tumors? How do we stop the progression of hearing loss? Trying to correlate the hearing test with tumor growth, unfortunately, is not predictable, meaning some people, their hearing will drop and the tumors don't grow. Some people, the tumors grow and the hearing does not change. But the good news is there's quite a bit of research. In fact, our group and many others are working on different clinical tests in order to try to help predict this, and more importantly, how to stop it or how to try to shrink the tumors or to restore the hearing. And so that's what we're going to be talking about now, is how do we treat tumors and the hearing issues. So our next speaker is going to be Dr. Mahoubi, who's going to talk about an overview of the auditory system and NF2-related hearing loss.
Thank you so much for having me. It's a pleasure to be talking in this webinar today. I believe I have control over the slides. Let's test that. All right, so I will be talking about an overview of the auditory system and then the mechanisms of hearing loss in NF2. So to understand this, first we need to kind of review the anatomy of the ear. And as many of you are likely familiar with the anatomy, we have the external ear, which consists of the outer ear or auricle, ear canal. And then we have the middle ear that is kind of bounded by the eardrum and the surface of the skull base on the inside, which then contains the inner ear organs. So the way we hear is that when sounds enter the ear canal, they essentially hit the eardrum. They cause small, tiny vibrations. And we have the three little middle ear bones that they transmit these vibrations to the inner ear level where the cochlea is. And then the inner ear essentially receives it and turns it into a signal. So if we look inside the inner ear or inside the cochlea, you see that there are different chambers, and the one in the middle that is called scala media on the left side, it actually contains the hearing organ or organ of Corti. The picture on the right side kind of shows a zoomed in view of the inner ear. And here we have the outer hair cells and the inner hair cells. And what they do is that they turn these little vibrations inside the inner ear fluid and the sounds into electrical signals that can then be taken to the brain via the nerve. The reason the cochlea is kind of looking like this, kind of spirals up, is that the way it's organized, it kind of goes from high pitches to low pitches, almost similar to a piano keyboard. So depending on sometimes which part of the inner ear has issues, you can have different kinds of hearing loss and hearing loss in different frequencies. So once the inner ear turns the sounds to a signal, the nerves then take it to the brain. So we have the hearing nerve or the cochlear nerve and the vestibular nerve, that is the nerve of the balance, as well as the facial nerve, pass through this bony canal, and then they exit the skull base, and then they enter the brainstem and the brain. So this is exactly where the schwannomas can occur. And therefore, one of the mechanisms of hearing loss would be essentially just direct impact of the tumors on the nerves at this location. And if we look at kind of like a closed-up view of the internal auditory canal, which is the bony canal that houses the nerves when they exit the inner ear into the brain, we see that the relationship between the facial nerve, the vestibular nerve, and the cochlear nerve. So again, depending on how big the tumors are and where they are arising from, they can impact one or all three of these nerves. So hearing loss is the most common presenting symptom in vestibular schwannomas, and all NF2 patients will experience hearing loss at some point. However, the timing can vary between the ears, and as Dr. Slattery mentioned earlier, the tumor size, distance from cochlea, and the nerve of origin do not always correlate with the degree of hearing loss. And obviously, another mechanism for hearing loss in NF2 patients could be iatrogenic hearing loss, or hearing loss as a result of an intervention, such as a surgery or radiation. But putting that aside, in terms of what the tumor can actually do to our hearing and auditory system, the most common mechanism is thought to be direct compression or stretch of the cochlear nerve. And as these tumors grow, even though there's not sometimes a direct correlation, but overall, as the tumor gets bigger, it can put more pressure on the nerve or stretch it beyond a certain point that can result in hearing loss, which would be very common. However, there are other mechanisms that have been proposed for hearing loss. So some studies have revealed that there is evidence of hearing organ level injury. And these knowledge come from post-mortem studies on patients with vestibular schwannomas, and histological and pathological analyses reveal that even though the tumor grows on the nerve, you can actually have damage at the inner and outer hair cell level inside the cochlea. And another mechanism that has been proposed for the hearing loss is loss of cochlear neuronal cells at the level of the cochlea, which again, these are for the most part farther apart from where the actual tumor is. And this is thought to be due to changes to the nerve structures and potential secretions by the tumors that can cause these. And also some MRI studies with certain sequences called FLAIR, they can pick up precipitates inside the inner ear. And these are thought to be due to, again, protein level increases within the inner ear. And this actually has a very high sensitivity of predicting presence of hearing loss rather than the actual size or location of the tumor. So the studies that were essentially organized by House Clinic called an NF2 Natural History Studies. We do have a lot of information about, how the hearing loss can occur and progress over time from these studies. One of these studies that was published in 2004, it involved 63 newly diagnosed NF2 patients, and during their first 2 years, actually 73% had stable hearing, and significant hearing loss occurred only in 27% of these patients. And what was interesting was that patients with a family history of NF2 were more likely to have stable hearing. However, this was thought to be due to their earlier diagnosis, because someone in their family had NF2, and obviously they were recommended to get tested, and it was diagnosed earlier. And another one of these natural history studies, this one focused on 120 NF2 patients, and patients were followed, and it was noted that the median time to hearing decline was actually about 62 months. And median is kind of a statistical term. It essentially delineates let's say in this situation, the number of months that at least half the patients had the hearing loss at that point, and another half did not. So it essentially kind of cuts the statistical data in half. So with this study, 5% of them had evidence of hearing loss at 1 year, 13% at 2 years, and 16% at 3 years. So as time goes by, more and more patients will develop it, but the progression is slow, and most of them initially have stable hearing. And the progression of hearing loss, the rate of it was actually much slower than tumor growth, which had a median time of only 14 months. So again, just to kind of recap, as Dr. Slattery also mentioned, hearing loss does not necessarily correlate with tumor growth, and there are things we can consider to hopefully help preserve hearing in patients with NF2.
Okay, somebody asked about meningiomas in the chat. Meningioma is a benign tumor of the meninges, or the lining to the brain. And so in some patients with NF2, you can get multiple meningiomas. From the perspective of next step, I want to talk about the outcomes of current treatment, meaning surgery or radiation therapy. Next slide. When we talk about this, there's a couple different things we have to think about. Again, we want to, observation, I think, is still the best option for people when the tumors are small. Unfortunately, the hearing can still progress when we do that. Usually we'll do an MRI scan at 6 months, and then if people are, because we want to identify fast growers, once the growth pattern is established, then interval imaging can be done appropriately. Next slide. From the standpoint of surgical options, we usually talk about middle fossa, retrosig, or translabyrinthine. The middle fossa and retrosigmoid approach are usually what's used for hearing preservation. In our experience, it's best to go after smaller tumors. Middle fossa is the most common thing that's done. And there's usually a couple different options to consider. The first is what's called decompression. So when we have small little tumors like you see in the MRI scan, usually what we do is just remove the bone from around the tumor. We'll decompress the bone and decompress the tumor. Next slide. What that does is we do not take the tumor out, but it gives it chance for the compression not to be as good. And what we found when we do this, that at 1 year, most of those patients still have very good hearing. So these are in patients where maybe the tumor's growing, it's too big to remove, or it's a cochlear nerve tumor, I mean, it's on the hearing nerve. And so we'll remove the bone from around the tumor. And then what we find is for a couple of years afterwards, we have pretty good results in monitoring things. The problem is, if you have a big tumor, that decompression procedure does not work quite as well. Next slide. That's when we'll usually talk about taking out totally the tumor. And this is one of our earlier studies of 40 patients looking at the size of the tumor. You can see most of these tumors were smaller. They were less than 2 centimeters in size. And so in this case, next slide, we're going to take the tumor out. When we do that, we find that we're able to preserve the hearing about 65%. At the exact same preoperative levels, about 50%. But we've had over now 50 patients who have had hearing preservation on both sides. But these are, again, people that we usually do it very early for when the tumor is still small. Next slide. Now, we also looked at what happened when we do this in children, because sometimes these will obviously present some tiny tumors in kids. And in those cases, what we found, next slide, was the chance of hearing preservation was a little bit lower than those in adults, but still very good facial nerve outcomes. Bilateral hearing preservation was done in 75% of those patients. One of the things that's happened since 2013, chemotherapies come along. So many times we'll get people, the surgical approaches are not as aggressive as they were in the past, just because the chemotherapy options are actually working out pretty well, but it's still something to consider. Excellent hearing can be maintained versus the middle cranial fossa approach in patients who have small tumors. It does allow us to preserve the cochlear nerve or the hearing nerve, so we can actually use a cochlear implant somewhere down the line. But when there's other tumors that grow later, facial nerve tumors or other tumors on the hearing nerve, that's why we have to continue to monitor patients, because those are the ones that I found that when we preserve it, for instance, in children, 20, 30 years later, those are the tumors that can sometimes be a problem. But again, with chemotherapy, that's actually changed some things. Next slide. The other thing to think about is radiotherapy. Radiotherapy is now done. There's really 4 different types that are typically done: gamma knife, cyber knife, true beam, or proton beam. Next slide. When we look at the results, this is gamma knife, and this is one that's probably pretty consistent with many of the others. We found that at 1 year, that the chance of hearing preservation is about 95%. But what you see after 5 to 7 years, that drops down in NF2 patients. So the outcome from hearing is that initially we have good hearing preservation, but over time, the effects of radiation many times will affect the cochlear nerve or the hearing nerve, and then the hearing can go out. Next slide. When we look at proton beam is usually used as salvage therapy, and there's really been no reports of hearing preservation with proton beam. We do know that overall the NF2 results are poorer than non-NF2 results, so people that have what we call sporadic tumors have better outcomes than patients with NF2, unfortunately. And I think that has to do with the fibers of the cochlear nerve or hearing nerve wrapped up inside the tumor, so that when you radiate the tumor, you radiate that as well. Next slide. So overall, when we talk about radiotherapy, what we will say is that the results for patients who have NF2, unfortunately, are slightly worse than sporadic tumors, which I just talked about, and that's with all the different types of modalities. The good news is that if somebody does have a vestibular schwannoma and has radiotherapy and they lose their hearing, as long as the hearing nerve has not been removed surgically, if it's still there from radiotherapy, we can usually consider a cochlear implant that actually works out pretty well. So I'll turn that back over to Dr. Mahooby.
All right, so next I'll be talking a little bit about chemotherapy and its effects on hearing. So, as with many other conditions and tumors, at some point, chemotherapy agents were also started to be studied for NF2. And the first study that was published was in the New England Journal of Medicine in 2009. And it was an agent called bevacizumab. And since then, various medical therapy options have been investigated. So bevacizumab, which is commercialized under the name Avastin, is still the most studied and established chemotherapy agent. It is an anti-VEGF monoclonal antibody, and VEGF stands for vascular endothelial growth factor. And we'll go over that in a little bit, but in essence, it is a protein secreted by the tumors to improve vascularization and receive more blood flow. Other investigated agents include medications that would cause inhibition of the epidermal growth factor receptor, or EGFR pathway. Erlotinib and lapatinib are the two of these medications that were studied. The first one was not shown to be effective, and then the second one, the latest publication was a phase 2 clinical trial, and they still have not published the phase 3. So it is still an investigational option. And then the second route would be inhibition of the mTOR pathway, and everolimus is a medication that has been tried and again did not show great results. So as of now, for the most part, bevacizumab remains the main option. So it is a recombinant humanized monoclonal antibody, and it addresses VEGF. It was first FDA approved in 2004 for combination use with classic chemotherapy for metastatic colon cancer. And the way it works is that the tumors, they produce the VEGF, and then you have the VEGF receptor on the blood vessel side, and it essentially promotes vascular growth. And Avastin or bevacizumab would block these receptors and neutralize the effects of the VEGF, and this can help prevent the tumors from further growth. So the study that was in 2009, they reported that 100% of the vestibular schwannomas were expressing VEGF, and they offered this treatment to NF2 patients with growing tumors for compassionate use. And initial data actually appeared promising, and that kind of started the opened the door to more studies in the future. So they had 10 patients, and they reported that in 9 out of 10 patients, they noticed a volume reduction. And actually, in 6 out of 10 patients, patients had more than 20% of volume reduction. 7 of these patients were eligible to be evaluated for hearing outcomes, and 4 out of these 7 actually reported improved word recognition scores. And as many of you likely know, when you do a hearing test, second part of the hearing test after the hearing thresholds are identified is to actually play a recorded set of words, and the patients will repeat them back, and then a percentage is reported. So this is called the word recognition score. And this is what actually matters in terms of hearing rehabilitation options, because if this percentage is above 50%, that would be considered an aidable ear, and patients can easily put a hearing aid on it. So the results that they reported was improvement from 8% to 98%, 34% to 76%, 0% to 40%, and 76% to 94% of word recognition scored. And obviously 100% would be ideal. So these results looked promising. So it is still considered off-label use for NF2, and it is not FDA approved. And as of now, it can be considered in patients with growing bilateral vestibular schwannomas where hearing preservation is a priority, or rapidly growing tumors that are not safe to have surgery, and also patients who are poor surgical candidates or who just wish to delay or avoid surgery. So since 2009, multiple studies have focused on studying bevacizumab, and the recent systematic review that was published in 2024 kind of looked at all those studies and compiled a list and aggregated the results. And systematic reviews are kind of research studies that the authors or the investigators, they don't directly study a medication or a treatment, but they look at all the publications out there and try to extract all the high quality data and kind of give you kind of a comprehensive review. So pretty much it will summarize everything that has been published up to that point on the topic. So they identified 9 studies with complete data on tumor size and hearing status and side effects. And they had on aggregates 176 patients. The average age was 27 years, and there were 86 males and 90 females. So this table kind of summarizes the aggregate results of all those 9 studies. So there was a partial tumor response on average in 40% of the patients. And then 50% had stable disease and 10% had progressive disease, meaning their tumors continued to grow. The aggregate result in terms of hearing improvement was 36%. 46% had stable hearing during that period, and 18% continued to have hearing loss. And severe side effects and adverse reactions were noticed in 13% of these patients. More kind of minor side effects were noticed in 69%, and 18% did not have any side effects with the treatment. So in general, in terms of effects of chemotherapy on hearing, the concern is obviously number one with side effects, because only 18% did not experience the side effects. So this would be something that needs to be considered. And also the duration of the effects are not clear, meaning even though during the study period, which are mainly kind of short in terms of timing of NF2 patients, but even in that period, it is unclear after you stop the medicine how much of that progression could be lost and what the long-term outcomes are. So these are kind of things that need to be still studied with the chemotherapy route. And also these studies have had variability in dosing and administration intervals, and the duration of the follow-ups are also different. So certainly these are areas of research that still needs to be completed, and hopefully we'll have more data on that in the future. And in terms of the side effects that were reported, these were kind of the common ones that were reported: hypertension, proteinuria, which means essentially peeing protein into your from your kidneys into your urine, which is not good. And embolic events, including blood clots and pulmonary embolism, things like that, fatigue, headaches, GI symptoms, epistaxis, which is nosebleed, impaired wound healing, and also menstrual problems in women. So these are things to be considered. But at the end of the day, while patients are on it, some good results in terms of hearing could be expected. All right, with that, I'm going to turn it over to the next speaker, Dr. Cooley.
Hello,
Yeah,
my
so
name is Isaac Cooley. Dr. Slattery, did you have...
no, I was going to introduce you, Isaac. I'm very happy to have you on board today. Thanks so much.
Thank you so much. I'm happy to be here. I'm a cochlear implant audiologist here at House Ear Clinic. So I'm here to talk a little bit about hearing aids and cochlear implants. So Dr. Slattery and Dr. Mahooby did a great job at kind of explaining how hearing loss can stem from NF2, but it could stem from something else. Maybe it's age-related hearing loss. Maybe we're dealing with both at the same exact time. So what do we do about it? How do we intervene? My job, in part with Dr. Slattery and Dr. Mahooby, is try to figure out where the lesion is coming from. Is it from the outer hair cells, cochlear neurons, the nerve itself? So step one would be to come on in for an evaluation. You most likely already have received a hearing test. On the screen here, you could see 2 examples. In the right ear, we have a pretty severe hearing loss. In the left ear, it's fairly normal. This is an audiogram. We typically read it left to right. So it goes from really low frequencies all the way to really high frequencies. And from top to bottom, it's going to be really quiet to really loud all the way at the bottom here. Every patient is going to have some different type of hearing loss. No hearing loss is the same. Our job is to try to figure out what type of intervention would be best fit for that ear and for that patient. So you can see the shape and configuration is going to help us know what might be best. Dr. Mahooby talked about our word recognition score. That's another great indication to try to figure out whether a hearing aid could be best fit for the patient, a cochlear implant, or possibly an auditory brainstem implant. So we'll skip on over to the next slide. So we'll start off with hearing aids. Maybe you have some type of hearing loss, and one ear or both ears, but it's not significant enough to have a cochlear implant. There are different types of hearing aids out there. It's very important to keep in mind that there are hearing aids and there are over-the-counter amplifiers. Over-the-counter amplifiers have been recently FDA approved, and they are great for people who have a very mild to moderate hearing loss. If you have something more than that, maybe we need to go with the traditional hearing aid option. There's a whole bunch of different options, and these are going to be best discussed with your audiologist. Okay, so hearing aids are going to be more frequency specific. So I could adjust certain frequencies, while some over-the-counter hearing aids or amplifiers are just going to increase overall volume. These devices need to be reevaluated. We need to get our hearing tested annually. And in conjunction with Dr. Mahooby and Dr. Slattery, they're probably going to recommend routine MRIs as well. Now, what do we do if a hearing aid is not enough? Like Dr. Mahooby said, our word recognition score is very important because we could amplify as much as we want, but if our cochlea, the hearing organ here, is done, we're working with a broken speaker. So at that point, we move away from acoustic intervention to electrical stimulation, and that's the cochlear implant here. We look for patients who are scoring about 60% word recognition score or less. Those are going to be our cochlear implant candidates, depending on other factors such as nerve integrity. So your speech information is going to drastically improve compared to a hearing aid, because again, we're no longer supplying acoustic amplification, we're going straight to the nerve. There are two different parts to the cochlear implant. We have the external device. This could also be known as your speech processor. Inside this, you're going to have microphones, a transmitter, and a processor that converts acoustic energy to digital energy. Then it's going to send that signal to the internal device. This could also be known as your electrode array. So this consists of a processing chip. It has multiple electrodes that go all the way deep into the cochlea and hugs around the spiral ganglion cells so that it stimulates the nerve directly. Again, we try to organize these tonotopically. That means we go from really high pitches here all the way to really low pitches face to cochlea. Okay. One thing to consider, like I said before, all ears are going to be different. Maybe we have a severe to profound loss in the left ear and maybe a mild loss in the right ear. I wouldn't treat them the same. Again, we want to look at the ear-specific information. So some patients benefit with a cochlear implant on one ear and acoustic hearing on the other side. So one might have a hearing aid on one side, a cochlear implant on the other. The cochlear implant is going to give you that really good speech understanding. Like I said before, sometimes hearing aids don't provide enough speech understanding, so that's where the cochlear implant comes in. But on the other side, you're kind of well balanced because now you're getting the good low frequency and possible natural hearing from the hearing aid. So you almost get the best of both worlds. Again, this is very patient specific, and we have to determine this with the hearing test and cochlear implant evaluation. One thing to note, with a cochlear implant evaluation, we evaluate you with hearing aids on. Are they providing you enough information? Are you getting enough speech clarity? We could also look at it in a quiet sound booth, but we could also introduce some noise. An ideal situation would be a quiet room, but as many of our patients experience, once they step into background noise, that's where they get the most difficulty. So we'll evaluate them as well in quiet and in background noise to see what might be the best intervention for them. And Rebecca Kale, Dr. Kale, if you'd like to jump in.
Okay, thank you everybody for having me. I'm going to now move forward to talking about an additional intervention choice that you have available depending on where you are in your hearing journey. Next slide, please. Okay, so the next intervention we're going to talk about is the auditory brainstem implant. And so, depending on where you are and the type of hearing loss you have, you may end up needing what is called an ABI. What an ABI is designed to do is really to restore your hearing when there has been a severed nerve, meaning that a cochlear implant or hearing aid are no longer appropriate based off of where you are in terms of the tumor removal and the outcomes you've had with that tumor removal. And so if you can no longer stimulate that nerve with a cochlear implant, we have to bypass the nerve and we now stimulate what's called the cochlear nucleus complex on the brainstem to allow for a different type of stimulation for that patient. Once we get to this point, it's the audiological criteria that we talked about earlier isn't really necessary based on that nerve has been severed. And so that in terms of the point, we really need to move on to a different type of intervention. So when we're comparing cochlear implants to ABI, the place of stimulation does differ in terms of the placement and us bypassing that nerve to ensure that we are able to get past the place that it has been no longer available and allowing that brain to allow you to hear the sound. And so in terms of what we get for expectations with ABIs, you're now at the point that you should be able to hear medium to loud environmental sounds, and there should be a detection of conversational speech. In addition, most ABI recipients do have the ability to have perception and rhythm and volume, as well as have some limited speech recognition if they're using lip reading. And they do have some recognition in terms of environmental sounds. So that's important in terms of safety and your ability to potentially hear different environmental sounds. I did notice a question in the chat about are there ways to improve the ABI and the sound quality? Some of the research is showing that there is improvements all the way out to 3+ years. And so continuing to wear that device, potentially coming in for reprogramming and allowing us to monitor performance would allow for potentially some improvements. When we look at cochlear implants in general, what we do know that and ABIs in general, when we talk to these recipients, the important part is that we want to ensure that we're addressing the hearing loss, meaning you don't want to wait to get your hearing loss treated, no matter what that hearing loss is or that treatment option is. So it potentially could be a hearing aid, it could be a cochlear implant, it could be an ABI. But what we hear from our recipients at Cochlear is that the important part is that they should have gotten treated earlier and that they actually address the hearing problem. So I do encourage you, no matter where you are in terms of the type of hearing loss you have, that you go see your local audiologist or your team of audiologists that you're dealing with potentially at Halcyon and look at getting evaluated for either a hearing aid, cochlear implant, or ABI, depending on the stage of hearing loss. Next slide, please. So we are going to move on to the next section. So once you get your cochlear implant or ABI or even hearing aid, there are different additional tools that can be used to help you with assisted communication, meaning there are a number of rehabilitation resources available to help you ensure that you're progressing as you need to with whatever type of intervention you have. There are resources to help you hear better within the telephone, within music, within noisy environments. And the manufacturers that you work with the hearing aid manufacturers or the cochlear implant manufacturers, all have these different types of resources and are willing to help you, as well as your audiologist. So if you're struggling with any of these areas, please reach out because there are tools that we can use to enhance or improve your listening ability. Next slide. Some of the other options as you move along is we may ask that you add additional technology in terms of helping you in different noisy environments, such as a remote microphone, meaning that you're almost giving the person that you want to hear a microphone so you can directly stream into your hearing aid, cochlear implant, or ABI. So we do have situations that will help you in more challenging listening environments if you need help with that. Next slide. And what we find is that increasing your ability to these rich language environments does allow you to move through your milestones and reach your hearing milestones at a faster pace, as well as increase your ability to hear in those difficult listening situations. So adding additional tools to your toolkit to help you improve your overall listening skills is really important to make sure that we're moving along to make those developmental milestones and ultimately improve your overall hearing ability. Next slide, please. And what we found is that by improving that signal to noise ratio, that ended up improving the overall outcomes of patients. And so by using these different technologies, there are ways that we can get you to improve your overall outcomes with your hearing devices. Next slide. And these are some of the options available that we have. And so as you move through your hearing journey, this is something that you can discuss with your audiologist. Are some of these options available to help me in these challenging listening environments, in these noisy situations, or going to different environments like church, etc., to help overall improve the challenges that you may be experiencing. Next slide, please. One thing that I would say that we also have available that I would encourage you to use is if you're joining meetings like this, something like closed captioning is always important. There are options to use ASL interpreters or different individuals to help assist with your overall hearing. So if you are struggling in specific environments, reach out to your audiologist because they have a bunch of tools in their toolkit that they can use to help you hear overall, especially on things like Zoom calls, knowing that we are a digital world now. So if you need help in any of those environments, please further investigate them because they are available out there for you. And we also have resources available through Cochlear or the other manufacturers. I do have some external resources listed down below, such as TED Talks or Angel Sounds. These are different resources to help you practice potentially your hearing ability or hearing with your different devices. So for example, the ABI, you can practice and improve your hearing ability over time. But there's things like TED Talks that can help you learn more about your hearing information. So there's a lot of resources out there and we can help you direct you depending on what you need. Next slide.
I could jump in. So this is kind of just a couple of tools that I use day to day. One is going to be live captions. We should all have live captions built into our phones. On the screen, you can see where to find them, at least with an iPhone. I know Androids are going to be a little bit different. If you're looking for access to full or total communication, this is a great option. It will live transcribe directly on your phone. You could use it anywhere you go as long as you have service. Another thing that you could see is a caption call phone. This is provided due to the ADA. It is a completely free service. There's a link here. We could get that to you if you're interested in it. I have quite a few patients that use this day to day. It is a landline. A representative from Caption Call can come directly to your house and install it for you and get it set up. Live transcription occurs on the screen here, as you can see, so that it's just a lot easier to communicate over the phone.
So we'd like to thank everybody for attending this webinar today. And we'd also specifically like to thank the Children's Tumor Foundation for their support of the webinar as well. So this webinar has been recorded and will be uploaded into the YouTube channel, as I mentioned. We are going to now address some questions that have been put into the chat, but I thought I would just go ahead and make those disclosures already. So there's a couple of questions that I think came up. So let's talk first about, let's see, I think Dr. Mahooby, I'm going to ask you if you wouldn't mind talking about the Bernatinib for growing vestibular schwannomas. I see that you responded to the text, but maybe you could go ahead and share with the rest of us about that, please.
Yes, so this is one of the newer agents that has been studied. Essentially, it works on the tyrosine kinase as an ALK inhibitor. So there was one clinical, I think, major clinical trial that was published, as far as I know, and they looked at patients with NF2 and looked at all tumors. And on the vestibular schwannomas, I don't think there was much of a benefit in terms of causing essentially like partial like shrinking of the tumor size, but in terms of hearing improvement, it was reported in about a third of the patients, but this is again just one study compared to bevacizumab that has been extensively studied. So it still remains investigational at this point, and its long-term safety and efficacy profile are still not known for NF2 and specifically for vestibular schwannomas. But there are also many other medications and chemotherapy agents that are being studied. So until we have kind of more robust evidence, they remain investigation.
So, and then there was a question about effects of pregnancy hormones on tumor growth for NF2. And this has been an active area of interest and discussion in the NF2 community, both from the patient perspective, but also the clinician scientist community as well. We do know that vestibular schwannomas have estrogen receptors on them. There have been cases, mostly sporadic tumors, that have had undergone rapid growth associated with pregnancy. With NF2, there is less data that has been gathered. In fact, I think many times the reason is that people that have NF2 are encouraged not to get pregnant. We do know now, though, that there have been some cases with in vitro fertilization that's allowed that to occur. But from the standpoint of hormone receptors or hormone therapy, and NF2, it's still an unanswered question. So I wish I could give you a little bit more data on that. Another question here, Isaac, I'll ask you to take this one, Dr. Cooley. Someone said they speak very little ASL, but they'd like to know more about the process of finding an interpreter just in general. I know I had a patient just the other day who was in, and she pulled out her phone and got an ASL interpreter on the phone with one of the apps. So maybe you could help share with patients how they can find an interpreter.
Absolutely. Most of the places that I've been have a mandated interpreter, and that's usually through some iPad. I don't know any specific apps. Dr. Kale, do you happen to know any resources for ASL?
I don't know any of specific apps either, but I'm assuming that would be a pretty easy Google search if you were to look it up. But I do know a lot of times if you ask the local, like it'll be dependent. I noticed it doesn't sound like you live in California based on the question. It'll be dependent on state by state. Typically, if you ask the audiologist, they probably have a group of interpreters that they work with. So that would be a good starting place. And if you were to probably put in your app interpreter, I'm sure something would come up very easily for that option.
Okay, and then Dr. Kayla, I'm going to ask you a question that was also here. Someone said they had an ABI in the past, and that ABI, they lost electrodes when it was reprogrammed, but the question is how well should they come in, or when should they come in for reprogramming? I suggested that they probably do want to come in for reprogramming, but you want to talk about how often patients with ABI should have reprogramming?
Sure. So once we have your maps established, typically we say to come back on an annual basis, unless you've had a change in your hearing. So if everything is working as expected, I would say annual basis is expected. If there is a change in your hearing, then call your audiologist up and go for reprogramming. There is a possibility that you have a change in your map, especially if there has been a change in what's going on with your tumor. And so that might mean that we also provide a referral back to your physician to look at additional imaging or management of your tumor. But it also could be something that we could do in terms of reprogramming. So there are options. The device is quite flexible. There are options that we have to maybe help with some of the reprogramming and allow you to have different hearing than you are potentially at right now.
And I just did an email link about apps for sign language interpreter. Apparently, it's a deaf language app but it is a subscription service. So obviously, you have to pay for that. And then there was another question about if there was any increased risk of cancer in patients who have NF2. And the answer to that is there is not been found to be any link to cancer. Now, just to kind of clarify that, if you talk about the NF2 gene, the NF2 gene is involved in many different types of cancers. However, patients with NF2 do not experience an increased risk of cancer. And the reason I bring that up is because you may see, oh, the NF2 gene was involved in this cancer or that cancer. But the reality is it's not involved with, or patients who have NF2 do not have an increased risk of cancer. I think that's the take-home message for the group of patients who have NF2. The good news is the fact that NF2 is involved in other cancers means there's a lot of other researchers who are also investigating how the NF2 gene works, which I think is going to be helpful for us, because I know we're working with some different laboratories that are doing work on different types of cancer, and they're specifically studying the NF2 gene. And we're hoping we've actually identified, and as of others, some different pathways and potentially additional drugs. So we're looking for additional drugs that can potentially be helpful long-term with NF2. But again, bottom line is if you have NF2, you do not, NOT, do not have an increased risk of cancer. So unfortunately, if you've had cancer, it's just for other reasons. And we're obviously sorry that people are having to deal with that, but it's not related to the NF2 part. So I don't see any other questions in the chat. I would like to give a hand of applause to our different presenters today. I thought everybody did a great job. We kept on time. It was wonderful. Does anybody want to make any additional comments? Wonderful. Well, again, thank you for attending this webinar. And again, thank you very much for the speakers that put the slides together and did a great job speaking today. So I'd like to really commend each of them. So thank you all very much. And again, thank you to the Children's Tumor Foundation, and thank you to the House Institute Foundation for the support putting this wonderful webinar together. So everybody have a great afternoon. And for those of you who are dealing with cancer, we hope that things will go well with that. Thank you very much.